My name is Terry Walters. I'm the program specialist with the National Kidney Foundation of Michigan. We're working with Prism Primary Care and MCT2D on this quality improvement program to increase the uACR in screening for kidney disease. So we'll go ahead and kind of get started. I like to throw out there that I am not a clinician. So if there's any clinical questions, I'd love to have them and I will vet them through our nephrologist or the nephrologist at MCT2D, get those answers and get those back to you, okay?
Thank you.
Okay, so the mission of National Kidney Foundation is to prevent kidney disease and improve the quality of life for those living with it. So the past 70 years, we've strived to deliver programs, services, and resources to those who need them most. So that's just a little bit about us. We do have 3 offices, one in Grand Rapids, one in Detroit, and our home office in Ann Arbor. So we'll talk a little bit about what kidney disease is. Excuse me. Um, so our kidneys are vital organs that keep the rest of your body, the body systems in balance. They remove waste product from the body. They regulate blood pressure, and balance the body's fluids and regulate electrolytes. Chronic kidney disease is the progressive loss of kidney function over time, leading to other health problems. Kidney disease can lead to heart attack, stroke, kidney failure, and even death. Um, Chronic kidney disease can creep up on you silently. People may lose kidney function for many years without any symptoms, which is why it's so important for the screening to be done and for patients to know what those numbers, their kidney numbers are. As you know, there's no cure for chronic kidney disease, but progression may be slowed down with that early detection. There's new medications out there, healthy eating and exercise, so that lifestyle change also. And just as a caveat, the end stage renal disease is that last stage of CKD where the kidneys can no longer function on their own, which requires dialysis or a transplant to survive. So here's a few stats. The low recognition of CKD is a public health problem because it's associated with substantial morbidity, impaired quality of life, shortened life expectancy, and excessive healthcare costs. According to the CDC, there are over 37 million Americans with chronic kidney disease, and it accounts for approximately $100 billion for Medicare beneficiaries with diabetes and CKD. So, of course, those later stages of chronic kidney disease are more costly than that. However, of course, awareness remains low. Approximately only 90% of individuals with chronic kidney disease are unaware that they have the disease. It's easy to miss because most people have no symptoms, like I had said previously, until their eGFR is significantly reduced and it's way too late to prevent those adverse outcomes. According to the CDC in 2024, kidney disease was the 8th leading cause of death. And I'm sure you guys know this. According to the National Institutes of Diabetes and Digestive and Kidney Diseases, diabetes and hypertension are the top 2 causes of kidney failure. To put this in perspective, about 64% of kidney failure in the United States is caused by diabetes or hypertension. And then approximately 40% of people with diabetes will develop chronic kidney disease at some time during that diagnosis. So the good news is some risk factors are modifiable, such as diabetes, high blood pressure, smoking. Managing these conditions is that key to preventing or slowing the progression of CKD. So of course, we can't do any of that if the people don't know that they have CKD, which is another reason why it's very important for that screening to be done. Some people are very surprised to learn that NSAIDs like ibuprofen or naproxen can cause kidney damage. And I bet most of us have this in our medicine cabinet. That's only one of the meds that can also, cause kidney damage. Some of the risk factors that are non-modifiable, which are family history of kidney disease, 60 years or older, and race or ethnicity. Also, people who have had an acute kidney injury are at a greater risk of developing chronic kidney disease later. So just a little bit of information here about the prevalence in Michigan. We have a dashboard that we use that is from Medicaid claims. And so this is 2022 data that we have and 2021. So overall in Michigan, there's over 1 million people with chronic kidney disease. To break that down, that's 1 in 7 Michiganders, according to the NHANES data. Among Michigan Medicaid, 88.2% of adults have been diagnosed with chronic kidney disease, but there's a substantial variation by county. As you can see on the map, there's a much larger concentration of the prevalence of chronic kidney disease in Southeast Michigan, the Thumb area, and Mid-Michigan. In 2021, 25.7% of Medicaid beneficiaries in Michigan were diagnosed with CKD. We are hoping to get some of this data updated because throughout these few years of really looking at the screening process, we're hoping that those numbers have, changed a little bit to where people are at least being diagnosed and being treated. So as you can see on the map, the dark orange is the highest prevalence around Michigan. The gold color is kind of that medium, and then that beige color is a low prevalence. Whoops, sorry. And then the screening, CKD screening in Medicaid adults with diabetes. This map shows the 2022 CKD screenings for Medicaid adults with diabetes, meaning they've received both the eGFR and the uACR. I did break this down into the counties. So the screening rate for Gratiot County in 2022 was 29.3, and Isabella County was 25.6. So the good news is that both of those counties were higher in those screening rates than the state average. But keep in mind, this is likely an underestimate due to the low screening rates in general. But the counties are doing, these two counties are doing better than the state of Michigan. So CKD, of course, is diagnosed using 2 simple lab tests. One is the estimated glomerular filtration rate, or the eGFR. That's the blood test that provides insight regarding overall kidney function. The second is the urine albumin creatinine ratio, which provides that insight regarding the extent of kidney damage. So just a little bit, the urine albumin, it's a protein that's found in the blood. Healthy kidneys don't let that albumin pass into the urine, but damaged kidneys do let some of that in. Urine albumin may be an early warning of kidney disease before that eGFR has any decline at all. So it's important to look at both of those tests to really determine the likelihood of progression to kidney failure or heart disease. I know that through the MCPD, they're focusing on that uACR. But I also know from the QI and working with you guys that you are doing this for both the eGFR and the uACR. Um, per the ADA guidelines, everyone with type 2 diabetes should be tested annually. Type 1 diabetes should be tested starting 5 years after diabetes diagnosis. And per the KDIGO and KDOQI guidelines, people with other risk factors that we discussed earlier should be screened as well. The American Heart Association also came out with new recommendations in 2025 to also screen hypertension patients since it is one of the top two causes of kidney disease. Early recognition of CKD offers that opportunity to enhance the kidney protective care by improving management of those modifiable risk factors. That is controlling that blood sugar, blood pressure, better nutrition, changing that lifestyle, smoking cessation. There's also those newer medications that can slow the progression of kidney disease. That early detection also encourages appropriate and timely referral to nephrology. So members have, or patients have an opportunity to receive kidney education and select a treatment modality for end-stage kidney disease. We hear of so many times that people didn't know that they had kidney disease. They go into the ER having some sort of symptom and they're crashing into dialysis. So they don't even have that opportunity for that education or making that treatment decision on their own. So diagnosing CKD, the criteria is abnormalities of kidney structure or function that's present for more than 3 months with implications for health. So either of the following must be present for those more than 3 months: the eGFR of over 60, or markers of kidney damage, which can include the albuminuria, which is more uACR of more than 30. There's many others, glomerular hematuria, polycystic kidney disease. The eGFR results determine what stage of kidney disease a person has and how it needs to be treated. As I said, our goal at National Kidney Foundation is to ensure that early screening of CKD before a patient reaches that kidney failure. It is important to specify the stage of diagnosis, but also to classify the CKD based on both eGFR and the uACR. And we'll talk about that on the next slide. So this is the heat map. It's a grid from the KDOQI, the Kidney Disease Outcomes Quality Initiative. CKD is classified by identifying a cause of CKD, which we just discussed in the last slide, assigning an eGFR category, and assigning an albuminuria category. This grid shows the prognosis of CKD and cardiovascular death because they are so intertwined by both the eGFR and albuminuria categories. The grid depicts the risk of progression to kidney failure, morbidity, and mortality from low to very high, green, yellow, red, and dark red. The numbers in the boxes represent how many times a year the patient should be monitored. And then, of course, when it says refer, that means a referral to the nephrologist for consultation or management. We want to keep in mind that these are only parameters. It's based on expert opinion, and you have to take into account the comorbid conditions and likelihood of impacting change in an individual patient. So we'll take a 55-year-old gentleman who presents with hypertension. His eGFR is persistently at 65, so it would be in this mild and decreased. which is mildly decreased. If his uACR is 15, which would be here, um, this means that he's at low risk of progression and can be monitored once a year. But if his uACR is at 400 as opposed to that 15, then that puts him way over at high risk for progression. So that should be he should be monitored more frequently and then should be referred to nephrology. So this can kind of help, classify what kind of treatments and how often to do this testing for the best care for the patient. So I know that, like I said, the MCT2D program, they're monitoring that uACR. But I also wanted to point out the kidney health evaluation for the HEDIS. It is in line with the ADA guidelines and the National Kidney Foundation. The HEDIS KED measure was developed by NCQA, adopted in 2020. This is a incentivized measure for Michigan Medicaid health plans. There is a similar measure for MIPS. Note that the CPT codes that fulfill the measure to ensure you're ordering the correct labs. Um, Unfortunately, in Michigan, because we have so many different labs, the nomenclature for the uACR can vary by laboratory. It can be called random or microalbumin. But both the urine creatinine and the urine albumin should be ordered for best patient care and to meet those quality measures, and also to meet the MCT2D and to increase that screening rate for the uACR. Um, like I said, it's important to run both the eGFR and the uACR for that complete kidney health screening, but the MCT2D reports on the uACR only. So at the beginning of our quality improvement, we had the clinics fill out a questionnaire about, what kind of things, what kind of barriers. And I know that we have gotten some really great information. So the common barriers and solutions to CKD screening, this is pretty much a lot of the things that you guys are doing specifically at Prism. So the lack of reminders to order tests as a barrier, using those standing orders, for the MA to print for CKD screening that is signed off by the provider, using those dot phrases with chart prep, and then following that standard of practice and workflow for screening and CKD of high-risk patient populations that you guys have. Barriers of lab orders not completed by patients. Many times, if somebody is doing a call to remind of an appointment, or when they make that appointment, we let them know that they're going to need to give a urine sample when they go to the lab or when they come in, and blood will be collected also. Um, you can offer on-site laboratory services of the urine, collecting it if that's something that you're able to do. Not all of the rural communities or places have that option. Um, the busy primary care visit with many comorbidities. Activate a best practice alert. Continue to use those morning huddles to identify patients who are due for screenings. That's a great way. My understanding is that you guys have improved on that. And it's a great way to really see what is happening with the patients in the screening, even before you get that data from MCT2D. And then another one is the patient feels fine. They're unaware for the need for screening. So, explaining why that test is necessary. And on the next slide, there'll be a couple handouts. The MCT2D has the uACR handouts. One is for patients, one is for providers. And then also sharing the awareness campaign that National Kidney Foundation of Michigan has. Are you the 33%? And I'll go into that briefly in the next few slides. So these are the two slides from MCT2D. The very first one on the left is for people living with type 2 diabetes. It kind of explained what the test is, why it's important, how often they should get the test, and then some other resources that the patient can click on or scan to go to. The other one is for clinicians treating that type 2 diabetes, the urine albumin to creatinine ratio test. And it kind of explains why to order that albumin to creatinine ratio and understanding what it is and the role of that uACR. So those are two really good handouts, the one for the patients especially to help them understand. So 80% of slowing CKD progression depends on the patient's lifestyle and social drivers of health outside of your clinic. The support you can provide your patients is key to making healthy changes and reach their goals through small but meaningful changes. Getting tested, number one. The blood test, the eGFR, and the urine albumin creatinine. Um, Emphasizing treatment adherence. Most people with CKD have other chronic conditions and are on a number of, different medications. And you might play a role in coordinating that care and improving communication between the primary care doctor and the specialist team. Um, Controlling diabetes is important. The longer it's uncontrolled, the higher incident and risk of chronic kidney disease that there is. Same thing with controlling high blood pressure. That's taking their medications, home monitoring, that low sodium diet. Maintaining regular physical activity that's recommended of 150 minutes of moderate to vigorous activity a week. That doesn't mean that, the patient has to get up and do an hour every day, even 10 minutes every hour, or however it works for them to get to that point of that higher minutes, it will be worthwhile and helpful to them. And then, of course, weight management. If overweight, trying to lose that weight can help with the management of all of those, the diabetes, the hypertension, all of that. So, counseling patients to quit smoking and provide resources. I'm not going to go into depth on nutrition and chronic kidney disease. But be aware that people with chronic kidney disease should limit their sodium intake, which can impact their blood pressure. Per the ADA and KDIGO guidelines, they should limit intake of protein to 0.8 grams per kilogram of body weight in adults and with CKD stages 3 through 5, but not on dialysis. Patients should choose plant-based eating over over whole foods, over ultra-processed. Other nutrients of concern, of course, could be potassium, phosphorus, calcium, and it should be determined on a case-by-case basis. Patients with CKD can be referred to a registered dietitian for an individually tailored healthy eating plan. In the next few slides coming up, I'll also go over a few of the programs that NKF offers for free for your patients that can help them with that self-management of their diabetes or any of their chronic conditions. So it's also important for people to share with their care team if they're taking over-the-counter medications or supplements, which uh, going in and talking to the patient at intake, making sure that you're asking about those over-the-counter medications and supplements also, as I talked about, that some of these can damage the kidneys also. Any pharmacists on the team are a great asset to conduct medication reviews, educate patients, offer clinical recommendations, and troubleshoot any insurance or financial barriers. So the next few slides are some resources for you and your patients that there's links on there, but I can always send those out when I send the PowerPoint slides out so that you have those. This is the CKD management and primary care. It's the ADA guidelines. It was updated in 2025. So it kind of just starts out with the lifestyle, which is where everything starts out with the healthy eating, physical activity. And it kind of goes down in an algorithm of people with type 2 diabetes, that first line drug therapy, or individuals with type 1 and type 2, of how it's different and how they can be managed. So this is one that I will also send so that the providers or the nurses could have this if it's helpful. This is also a good algorithm for the CKD management. It talks about the condition and the risks, screening for CKD, whether it's a yes or a no. It tells you, if it's yes and it's high to classify it. And then it also has a little bit of information on some medications and things on the one on the left-hand side at the bottom. And then it kind of talks about that evaluating for chronic kidney disease, and it has a lot of the categories, what to do if it's detected, why you should classify CKD. So it's just a really good handout. Many of our providers that we have worked with really like this as a one glance thing to kind of help them keep on track, especially if they're newer to that early stage of CKD management. So this is the Are You the 33%? This is a kidney risk quiz. It also has social media messages, resources for patients, anything on there you can use. We do have this all in Spanish, Arabic, English. So 1 in 3 or 33% of US adults are at risk for kidney disease. Like I said, this has a communications toolkit that you can, share out. There's also a toolkit designed with input from Michigan's native and tribal communities. So it kind of gets everyone. On the web page, you can also, patients can also choose that language and it will come up in that language that they speak. So as I said, these include social media, text messages, sample emails, infographics. Some of our clinics have TVs in their waiting room that they can put things across. And so many times they'll use some of this. These toolkits have been approved by Michigan Medicaid for sharing with patients. So, that pretty much means that they've been approved based upon that reading level for health literacy and things like that. So, this also has a risk quiz that your patients, even your loved ones could take to find out if they're at risk. Um, Once they take it, I think it's like 8 questions. Once they take it, if they're high risk, they can choose to receive emails with additional information and tips for living healthy. I think those come out once a week. And so it's kind of helpful to get the word out. If you guys are interested, let us know. We do have like some tabletop Um, Things like what you see on the screen where there's the QR code where a patient could go in and actually take that test. So like I said, if there's any of these resources, I'll be happy to send you either electronic copies or hard copies. So you can see that we have many evidence-based programs. We have prevention programs, management programs, and physical activity and falls prevention. Diabetes and hypertension, as I talked about, are the top two leading causes of chronic kidney disease. So we offer a suite of evidence-based programs to manage those chronic conditions to prevent or delay progression of kidney disease. These evidence-based programs acknowledge each individual's role in managing their own condition. It incorporates medical management, maintaining life roles, and managing negative emotions, such as fear and depression, especially if they just were diagnosed with, stage 3 or 4 kidney disease that they did not know that they had for years. These programs can increase skill, knowledge, and self-confidence, which in turn increases that quality of life and leads to a better health outcome for the patient. These self-management programs, they won't conflict with the provider's instructions, recommendations, or treatments. Rather, they enhance that clinical care because they allow the patient to work on changing their health behaviors and they support disease-specific education. These programs are open to all adults living with chronic conditions. The only one that is billed to insurances is the diabetes prevention program, and that's for pre-diabetics. And if the insurance doesn't cover it, we still don't charge the patient. Um, we want to make sure that these are available for people if they need it. So here are some patient education materials, and as I said, at the bottom, those are direct links to them. I will be happy to send those out individually in the email with that I'll send to Mary, and so that you have them. They are available in Spanish, English, and Arabic. The one on your left is Take Care of Your Kidneys. It's just a really good handout for patients, kind of explaining chronic kidney disease. The one on the right is How Well Are Your Kidneys Working? And this is kind of a tool for the provider and the patient. Many of the providers really like this. It kind of goes over it. You write down their eGFR. It explains what it is. It shows, you can use the graphs to show where that patient is. The one nice thing about it is, how I had talked about how that the urine doesn't let albumin, into the blood system or leak out. At the bottom of the How Well Are Your Kidneys Working, right here, this is a picture, and we like to use the analogy of a coffee filter. So a good kidney doesn't let any of those coffee grounds or any of that albumin leak in. If there's any damage to them, this is what will happen, is that it will leak in some. So it's just kind of nice visuals to help the patient understand, what's going on. These are a few other ones that are good for patient education. This is the testing and early detection. This is the managing CKD. We have a really good that our registered dietitians use is the kidney friendly food list and tips. We do have registered dietitians that we can have do a presentation or anything, if the nurses or care managers or whoever might like to learn a little bit more about that with chronic kidney disease. Um, So like I said, I'll be sending out the PDF of the PowerPoint afterwards. So you'll have all of these educational links to share with your patients or with any of the other staff. Talking about quality improvement, we have here, it's called a Smarty Aim Statement worksheet. And a Smarty goal, it's an advanced goal setting framework that is a powerful tool for ensuring projects and initiatives are not only effective, but also fair, just, and benefit all its members who are working on the initiatives or projects. It is used in healthcare to drive meaningful system-wide change by embedding diversity, equity, and inclusion into the core of planning. So everyone's included, everyone's voice means something. This will always stay the same, but what the processes and things that are being worked on will different, and that's on a different worksheet of a PDSA, Plan, Do, Study, Act. And that's where things will change. So that's what I've got for you guys. Does anyone have any questions?
I don't think we do here in Alma, Terry. Mount Pleasant, do you have any questions?
No, I think we're all set.
Awesome. I will, like I said, my contact information is on the slide. I will send all of this to Mary and Julie, and they can share it with all of you guys. Feel free if there's something that you guys are looking for a patient or anything else, let them know or let me know. And we will work our best to get that to you. We're here to support you in what you're doing, and want to make sure that any of the resources that you need that we have or that we can build are shared with you.
Thank you, Terry.
Thank you.
Thank you so much, and I will get this out to you, Mary, so that you can share it.
Perfect. Appreciate you.
Thank you very much.
Thank you. I'll let you get back to the rest of your day.
Okay, thank you.
Thank you, Terry.
Terry.
Thanks.